This recorded lecture will be going over Chapter 36, Administering Intravenous Solutions and Medications in the Fundamentals textbook. The intravenous route is the primary method of supplying a patient with fluids and medications via the veins whenever a patient cannot take them orally. The IV route has the advantage of making drugs or fluids instantly available for circulation to all tissues. The disadvantage is that if an error is made, adverse effects will occur more rapidly. An IV infusion is the slow introduction of fluid into a vein. This can be used to maintain hydration. Examples of substances delivered by the IV route would include fluid and electrolytes that the patient is unable to take orally and in sufficient amounts, medications that are more effective when given by this route or can't be given another way, blood, plasma, or other components, nutritional formulas containing glucose, amino acids, and lipids. The average adult needs 1,500 to 2,000 mLs of fluid in a 24-hour period to replace the fluids eliminated by the body. Fluid balance is also affected by increased metabolic processes, for example, during a fever. The primary care provider considers laboratory tests related to electrolytes when ordering replacements, such as sodium, potassium, and chloride. All nurses must monitor IV therapy. In some states, the Nurse Practice Act and facility policy allow practical nurses to hang IV piggyback medications, add medications to IV solutions, calculate IV infusion rates, insert IV peripheral catheters, and teach patients about IV therapy. Often an extra course is required for certification for the licensed practical nurse to perform IV therapy and start IVs, and this is the case in Florida. The primary care provider orders the type of solution to be given, the amount to be infused, and the rate of the infusion. IV solutions are isotonic, hypotonic, or hypertonic. Isotonic solutions have the same concentration or osmolality as blood and are used to expand the body's fluid volume. When exposed to an isotonic solution, the body cells will stay approximately the same size. Hypotonic solutions contain less solute than the extravascular fluid and can cause fluid to shift out of the vascular compartment and into the cells. This can cause a dangerous situation, as cells can rupture. Hypotonic solutions are generally considered unsafe to administer to children. Hypertonic solutions have a greater tonicity compared with blood. They are used to replace electrolytes and, when given as a concentrated dextrose solution, will produce a shift in fluid from the intracellular compartment to the extracellular compartment, causing a shrinkage of the cells. On page 717 in table 36.1, we can see some common intravenous therapy solutions, their tonicity, and some examples of how they'd be used in a clinical setting. 0.9 saline, very commonly used, half normal saline. Dextrose, you can see, has many different concentrations, and we can also use it in different solvents such as water, saline, different concentrations of the saline, and then of course our lactated ringers. Solutions that are given intravenously need to be sterile. They're supplied in plastic bags, typically of 250, 500, and 1,000 ml amounts. The typical IV bag has calibrations along the sides, approximating the amount of fluid left in the bag. Many different types of administration sets are available, some of which are specific for the type of IV solution, IV bag, or IV pump. Administration sets can be classified as primary IV sets, secondary or piggyback IV sets, parallel or Y IV sets, and controlled volume IV sets. Change the IV tubing no more frequently than every 96 hours, but at least every 7 days for infection control purposes. The primary IV infusion setup will consist of a bag of solution, a regular tubing set, a needleless connector, and an IV stand. A filter can be added. The primary line usually has 1 or 2 injection ports. The primary IV tubing set used in the gravity delivery is sized by the number of drops per milliliter to be delivered into the drip chamber. There are 3 major sizes: regular drops, which are 10 to 20 drips per ml, macro drops, which are 10 to 15 drips per ml, and micro drops, which are 60 drips per ml. These are used when small amounts of fluid are required or when extreme care must be used to measure the exact amount, most often used for giving IV fluids to infants and children, recommended for older adults who have fragile veins. If you're using an infusion pump, you need to use the primary tubing that is designed to fit that pump. All types of tubing have a familiar roller clamp, which will allow for manual control in the event of any equipment failure or power failure. Medications to be given intravenously are often added to an existing IV line. This is using the secondary or piggyback intravenous method. The secondary bag containing the medication, also known as the piggyback, is hung higher than the level of fluid in the primary IV bag. This is so gravity will force it to empty first. It's important not to clamp or alter the flow of the primary bag. If the secondary bag is positioned correctly, the primary IV will begin to flow as soon as the secondary bag is finished. This is also handy because it will allow all of the medication within the secondary bag, including the tubing, to be administered through the use of the primary IV fluid. See the clinical cues on page 719. Scrub the hub is a slogan that was developed to emphasize the importance of using sterile alcohol pads to scrub the injection port with friction for at least 15 seconds whenever accessing a central line injection port or an IV connection. Exceed the standard of care by scrubbing the hub whenever you're accessing a peripheral IV line. A Y-type administration set is used to infuse certain blood products. The blood product is placed on one side, and a bag of normal saline is placed on the other side. The saline is started first, and then the blood administration is begun. Blood products are never infused into the same IV line as medications or other fluids. A dose of diluted medication also can be given through a controlled volume intravenous set. In most cases, an infusion pump is used to administer fluid or medication. Using a controlled volume set decreases the likelihood of fluid overload because only a specified amount of fluid is available to be infused at any one time. Some patients do not require fluid by the IV route, but may need to receive IV medications at intervals or have an IV access in case emergency medications are needed. One advantage of the saline lock is that freedom of movement for this patient is possible. The peripheral device is referred to as a saline lock, PRN lock, or intermittent lock. Filters will trap small particles such as undissolved medication or salts that have precipitated from the solution. This will prevent particles from entering the veins, and a special filter is always needed for blood components. The use of infusion pumps is an added safety measure in IV therapy. It is mandatory to use an infusion pump when patients are receiving total parenteral nutrition, or TPN, or for medications that require critical accuracy, such as heparin, insulin, cardiovascular medications, chemotherapy drugs, or medications that are used to induce labor. Programmed infusion pumps are more accurate and will provide a better control over the amount of solution being infused. These pumps will deliver IV fluids automatically at a rate that is programmed by the nurse. They have alarms that warn when the IV bag is empty or when air is present in the tubing or an occlusion has occurred. They will also alarm whenever the site is infiltrated. Remember that a pump is never a good substitute for a good nursing observation. Disadvantages of pumps would include the expense and special administration sets, as well as the possibility of pump failure. The U.S. Food and Drug Administration advises clinicians to consider the following strategies to help reduce any risk of infection to patients. or pump failure to patients. Have a backup plan in the event of pump failure. Clearly label tubing and pump channels with the name of the medication infusing. Always verify pump settings and have another nurse double check your settings whenever infusing any high-risk medications. Carefully watch your patients for any signs of overinfusion or underinfusion. Consult with super users for additional assistance and training. Report promptly any adverse events to the FDA and remove any equipment that is not working right. Some pumps can handle multiple infusion lines and can be programmed separately for each line. Patient-controlled analgesia, or PCA pumps, are pumps used for pain control and have a remote control button by which the patient can administer a controlled bolus of their pain medication. A mini infusion pump is used more frequently on pediatric units. An insulin pump is a small, portable device that can be programmed to deliver a continuous infusion of regular insulin that will mimic our normal physiology. Safety venous access devices will decrease the risk of accidental needle sticks. Venous access devices come in many different sizes, called gauges. The smaller the size needed, the larger the gauge number. Two basic types of IV needles and catheters are used for peripheral IV fluid administration. The wingtip or butterfly needle is meant for short-term therapy, such as to give single-dose IV medication or to obtain blood samples. These needles are rigid and may cause more discomfort than other needles. Mobility must be restricted to prevent dislodgement of the needle. Over-the-needle catheters consist of a needle with a catheter sheath over it. After the device is placed into the vein and the cannula is threaded, the needle is removed, leaving a flexible catheter in the vein. This can be seen on page 723, showing the placement of a peripherally inserted central catheter or a PICC line. And this picture can be seen on page 724, showing the placement of a subclavian central line. When a peripheral vein is difficult to locate in the adult, or the veins are not suitable for IV therapy, a catheter is inserted into the large subclavian vein and positioned into the superior vena cava, or the right atrium. This type of catheter can be left in place for 6 to 8 weeks. Peripherally inserted central catheters, or PICCs, or midline catheters, also known as MLs, are often used in children or in adults who need peripheral IV therapy that requires placement where there is a high blood flow. They are also first choice in home care IV therapy for up to 6 to 8 weeks. There are other vascular access devices that can be inserted by a physician or specially trained nurse. Long-term central venous catheters that are threaded to the tip of the right atrium of the heart are always placed by surgical tunneling through the subcutaneous tissue and then through the subclavian vein into the superior vena cava. Central venous catheters will range from 15 to 30 centimeters in length. Several types are available. Some will have a single lumen. Others will have 2, 3, or more lumens. These catheters are periodically flushed, much like a PRN lock, to keep these lumens patent. On page 723, see the clinical cues. Remember not to take the blood pressure on an arm that has a PICC or midline catheter in place. It's also very important to note the correct placement of subclavian catheters must be verified by X-ray before any fluid can be infused through them. An infusion port with a single or dual lumen catheter can be implanted. Most ports are placed subcutaneously on the chest beneath the right clavicle, and the catheter is then threaded through a large vein into the superior vena cava. Specially designed Huber non-coring needles are used to infuse solutions and medications through the port. Potential complications of IV therapy include infiltration, extravasation, phlebitis, systemic infection, and catheter embolus. This is a piece of the catheter obstructing blood flow. Medicare and Medicaid do not reimburse for infections or complications related to poor care of central line catheters. Infiltration is the most common problem encountered with IV therapy. Infiltration occurs when a non-vesicant fluid or medication leaks out of a vein into the tissue. Signs and symptoms include local edema, skin blanching, skin coolness, leakage at the puncture site, pain, and feelings of tightness and sometimes numbness. Flow can be slow and sluggish. However, this is not a definitive sign, particularly in the early phase of infiltration when the fluid can be progressively leaking into the surrounding tissue. If infiltration occurs, discontinue the infusion, remove the catheter, and reestablish another IV line in a different site. Fluid that is in the tissue will usually reabsorb within 24 hours. Follow your agency policy for treatment. Extravasation is the infiltration of a vesicant, a medication from an IV line. The appearance of the site and the patient's subjective complaints initially might be similar to those of infiltration, but the damage can go unnoticed for 48 to 72 hours. This can lead to severe tissue damage. Be aware of any drugs that might have any vesicant properties. For example, some antibiotics or certain anti-neoplastic drugs. Assess the site before administering the dose. Dilute the drug as directed, and avoid any vein sites such as the dorsum of the hand or the antecubital fossa. If extravasation does occur, stop the infusion, but do not discontinue the IV, as attempts will be made to aspirate the vesicant from the site. If an antidote does exist, it needs to be delivered directly to the problem area via the involved IV line. Phlebitis is caused by irritation of the vein by the needle, catheter medications, or additives in the IV solution. The typical signs of phlebitis are erythema, warmth, swelling, and tenderness. The IV needs to be discontinued and another site found for reinitiating IV therapy. Application of a warm compress to the inflamed site will decrease discomfort. Bloodstream infections are known as septicemia. These will occur when infectious pathogens are introduced into the bloodstream. Central line associated bloodstream infections, or CLABSIs, are the cause of thousands of deaths in the United States each year and will cost approximately $46,000 per infection to treat. Signs and symptoms are fever, chills, pain, headache, nausea, vomiting, and extreme fatigue. Blood cultures are ordered and aggressive antibiotic therapy is started. The IV site needs to be discontinued immediately. Other suggested interventions are rigorous hand hygiene, tubing, and scrub the hub for at least 15 seconds with alcohol whenever a port or IV connector is accessed. Antibiotic impregnated central venous catheters are another proven method of reducing infections in adults and are presently being studied in children and neonates. There are several additional serious complications of IV therapy. Catheter embolus can occur when a piece of the catheter breaks off and travels in the vein until it lodges. Air embolus can occur when changing bags or when opening the line of a subclavian catheter. Speed shock occurs when fluid or medications given by bolus are administered too rapidly. Speed shock is a systemic reaction that occurs when a substance unfamiliar to the body is infused rapidly. Signs of speed shock are lightheadedness, tightness in the chest, flushed face, and irregular pulse. The patient might lose consciousness, go into shock, and suffer cardiac arrest. Monitoring IV sites at least once an hour is a prudent nursing action. Visually inspect and palpate the site and assess the flow of fluid whenever you are at the patient's bedside. On page 726, see Table 36.2, Complications of Intravenous Therapy and Nursing Interventions. It'd be important to pay attention to the air embolus complication, which would produce a sudden drop in blood pressure and an increase in pulse. As a nurse, you would need to place the patient on their left side and lower the head of the bed. Inspect the IV infusion system for any disconnection or leak, and immediately notify the primary care provider. Each nurse is responsible for determining that the correct IV solution is hanging. The IV site must be assessed every 1 to 2 hours during a shift to ensure patency and absence of any complications. When giving IV medications, review the drug's action, possible side effects, correct dosage, and nursing implications, and the patient's drug allergies before preparing the drug. Always assess for adverse or side effects. Previously administered doses of IV or piggyback medications before administering the next dose. Assess the existing IV site and catheter size before beginning an infusion of a blood product. Allow time to provide care for the IV site, hang the solutions, change the tubing or IV sites, and perform any needed assessments. Allow extra time if you have to monitor a blood transfusion. On page 727, see the lifespan considerations for the older adult. Older adults who have IV fluid infusing are at risk for fluid overload. Auscultate the lungs at least once each shift for sounds of crackles. A rapid pulse, shortness of breath, and distended neck veins are other possible signs of a fluid overload. Students must have supervision whenever performing venipuncture. Before venipuncture is performed, gather the equipment, obtain or prepare the IV infusion, select the most appropriate vein, and prepare the site. Selection of a vein for IV use will depend on several factors, including the vein's accessibility and general condition, the type of fluid or medication to be given, and the duration of IV therapy. The veins preferred for infusions and intermittent doses of medications are those distal to the antecubital area. A new site cannot be placed distal to an old site. It is necessary to be able to feel or see the vein. It's important to start low and work up the arm. On page 728 in box 36.3, we can see some intravenous therapy guidelines. Keep the IV fluid sterile. Protect the catheter site from contamination to avoid any possible infection. Hang the fluids at the correct height. Carefully regulate the rate of flow. Monitor intake and output when a patient is receiving IV fluids or blood. Hang the solution that should run first in a higher position. Assess the site frequently for signs of complications. The factors that influence the rate of flow of an IV solution are catheter size, height of the IV solution bag, and the viscosity of the fluid. In the gravity method, the higher the IV bag, the faster the fluid will flow. Pumps will offer a variety of programmable functions. The standard IV tubing set will produce 10 to 20 drips per ml, and the pediatric or microdrop chamber will produce 60 drops per ml. On page 727, see box 36.2, calculating the intravenous flow rate. When the order reads D5 half normal saline at 125 ml per hour, use the following formula to find the amount of drips per minute. So it would be important to remember how to do that and practice those calculations for the exam. A device called a venoscope can be used to illuminate tissue and outline the vein. When your patient has an IV, you are responsible for ensuring that the correct solution is infusing at the prescribed rate. Patient movement can alter the rate. A primary responsibility of keeping the intravenous solution running is checking the IV at least every 60 minutes and observing each of the following points with your eyes, traveling from the IV bag down the tubing to the catheter site. Observe the IV flow. For the gravity method, the solution should drip into the chamber at regular intervals. Observe the rate of the infusion. Count the rate if you are using the gravity method. If it's too fast or too slow, adjust it to the correct infusion rate per minute. The infusion pump. If a pump is used, check the program rate and volume. The dripping in the chamber will occur intermittently. Observe the insertion site. Are there any signs of infiltration, extravasation, or phlebitis? Listen for patient complaints. An established IV should not cause pain or discomfort, and there should not be any leaking at the site. Observe for the level of fluid remaining in the bag. When 50 mL are left in the bag, a new bag should be added before the current solution is completely confused. Always check whether or not the tubing needs to be changed, no more frequently than 96-hour intervals, but at least once every 7 days. And always change the tubing whenever a new bag is hung. Check your facility's policy for the frequency of tubing changes. Each state will set the scope of practice for the LPN, but the organization can narrow the scope. The IV solution bag is hung from an IV stand or pole. Medications can be given by the IV route as a one-time, stat, or PRN doses, as multiple doses to be given at regularly scheduled times, or as continuous infusions. Some potent drugs, and those causing irritation in concentrated strengths, are diluted in 1,000 mL of fluids. If you have to add medication to the IV fluids or dilute medications, you must follow package directions for type and amount of diluent and use strict aseptic technique as well as a needleless device. The tubing is reused for subsequent fluids and additional doses of medication. This can increase a possibility of contamination. Giving a medication directly into a vein over a few minutes is called giving a bolus or IV push injection. On page 742, see the clinical cues. Most facilities have guidelines for IV antibiotic administration for community-acquired pneumonia, usually with the goal of the first dose of antibiotic to be given within 4 hours of patient arrival. This typically occurs in the emergency department. Nursing measures to meet the goals of the Joint Commission include scrupulous attention to dosage and adjustment of IV infusions, such as the heparin drip. Use of an IV pump is mandatory for safe delivery. Anti-neoplastic medications are also called chemotherapy. This is toxic to both normal and abnormal cells, as well as very irritating to the tissues. When an infusion is to be discontinued, the flow is stopped and the catheter is removed. Discontinuation is documented on the IV flow sheet. A transfusion is the IV administration of whole blood or of one or more of its components. Normal saline is the only solution used in conjunction with a blood transfusion. Packed red blood cells are commonly given for acute or chronic anemia. Platelets and fresh frozen plasma are transfused to replenish platelets and provide clotting factors. The patient must sign a consent to receive blood, and generally no more than 48 of 72 to 72 hours can occur before the transfusion. The consent form needs to be signed within 48 to 72 hours of the transfusion occurring. It's important to obtain baseline vital signs before starting the infusion of blood products. Then again, vital signs 15 minutes after it's initiated, and of course, vital signs when it's completed. Observe closely for transfusion reactions. Reactions to blood transfusion will usually occur shortly after the start of the transfusion, typically within the first 5 to 15 minutes. Reactions are most common when packed red blood cells or whole blood is given. Signs of reaction can include hives, itching, facial flushing, chills, back pain, apprehension, and fever. If a reaction to the blood occurs, the blood should be instantly shut off. Start the normal saline with fresh tubing to keep the IV access open in case of emergency drugs are needed. Notify the primary care provider immediately. Patients may require IV therapy for long periods. Short-term therapy is usually considered to last about 2 weeks, and long-term therapy is going to be 6 weeks or more. Total parenteral nutrition is primarily given through a central line. Evaluation will require constant patient assessment. Documentation of IV medication is done on the MAR or EMAR. Data included in the documentation are similar to those for other types of medications. IV fluid is counted as intake and recorded on the intake and output sheet. If you identify a problem, document your observations and include your follow-up actions to address that problem.